Dr. Sunil Khetarpal, very senior physician practicing in Salimar, very remote person. Dr. Ram Babu, very bright, working in Jaipur Golden Hospital. He is a senior consultant. Dr. Hemant Sharma is a professor in medicine, specialist rheumatology at Hindura Hospital. And Dr. Jagdeep Chuk, he is also senior consultant, very eminent practitioner. He is associated with Fortis Hospital, Salimar Bagh, as well as with own hospital, Satyam Hospital. So now I request the moderators or chairperson to start with the streams. Dr. Chairperson, please. Thank you.
So कितने लोग पार्ट ले रहे हैं क्विज के अंदर? तो एक टीम ये और दो, एक टीम ये और आपकी एक टीम कर लेते तीनों की. इज ऑल राइट? ठीक है, तो ऐसे करेंगे. आप लोग यहां से उठ के इस साइड आ जाओ, इधर आ जाओ, इधर आ. या तो वी हैव 5 टीम्स, टीम 1, टीम 2, टीम 3, टीम 4, टीम 5. ठीक है. डॉक्टर छाबड़ा, उनको बिठाना पड़ेगा जरा. चलो, वेरी वेरी गुड मॉर्निंग टू ऑल ऑफ यू. सो वेलकम टू द क्विज. हमारे पास 5 टीम्स हैं. There will be 4 rounds. Round 1 will be one liner. Round 2 picture, round 3 MCQs, and round 4 will be ECG. Each question has 10 marks. There is no negative marking, no pass, as we have very less time. Total 34 minute का time दिया गया हमें. So it's no pass. Prize for first, second, third team. In case of tie, decision will be by asking question to the tie team. We will tell you how many, and of course we will be telling you many golden points. Purpose of coming should be solved. When you go out, you should be enriched by huge amount of information. Decision of the quiz master, that is myself and my colleague Dr. Nityanand Tripathi, shall be final. Okay, so we start with team 1, team 2, team 3, team 4, and team 5. और कोई है? Anybody else interested? चलिए. Round 1, one liner. Team 1 आपके लिए. You get 15 seconds for each question.
Dr. Bhatia.
Yeah. जी.
हमें क्या करना है? तो बाकी
आपको नंबर दे देना. ये दिया हुआ है.
ये नंबर
सही. हाँ, 10 नंबर. बस. No negative marks. Yeah.
Hello.
Name any disease in which secondary hyperaldosteronism occurs without edema feet. Time out. The answer is severe gastroenteritis, Bartter syndrome, and Gentleman syndrome. Okay. Team 2. Which diuretic act at descending loop of Henle? Oh, Mike दें. Mike पास करते रहेंगे फटाफट आप. या जल्दी है फटाफट. No negative marking. No negative marking. To summarize, well, the answer is none. So let's learn the basic. Basic ये है कि a diuretic is a drug which inhibits sodium reabsorption at any part of the nephron. Descending loop of Henle is the one पे जहाँ पे सिर्फ water absorb होता है, sodium absorb नहीं होता है. So diuretic is natriuresis. क्योंकि वहां पे सोडियम एब्जॉर्ब नहीं होता, तो none of the diuretic act at descending loop of Henle. Question 3, team 3. Paradoxical bradycardia is seen in which condition? माइक लेते रहेंगे, साथ साथ आगे है.
Enteric fever.
Little louder.
Enteric fever.
Well, the right answer is pulmonary embolism. Golden line to remember. Most common symptom of pulmonary embolism is sudden onset of dyspnea. Tachycardia is the most common finding. मोस्ट कैरेक्टरिस्टिक फाइंडिंग इज S1Q3T3 वो सामने इसी दिया गया है, बट देर आर मेनी पीपल जहां पे ब्रेडिकार्डिया भी होता है, एंड दैट इज नोन एज पैराडॉक्सिकल ब्रेडिकार्डिया. ओके. Team 4, which electrolyte imbalance can happen with heparin therapy? Team 4. आगे माइक पास करते रहेंगे फटाफट. Which electrolyte imbalance can happen?
Hypocalcemia.
Say it again louder.
Hypocalcemia.
Hypocalcemia. Well, the right answer is hyperkalemia. Well, golden line to remember. Side effect of heparin therapy, hyperkalemia. Number 2, osteoporosis, and number 3 is thrombocytopenia, so-called heparin-induced thrombocytopenia. Ye thrombocytopenia is a unique thing. Despite thrombocytopenia, there is increased clot formation occurs. Now, एक और condition है जहाँ पे thrombocytopenia with increased clot formation. वो कौन सी है? Yeah, that is है DIC. No, PNH. Okay. Anyway, the right answer is hyperkalemia. अभी point नहीं मिलेंगे. Team 5. G6PD deficiency is a X-linked recessive disorder. So female are the carrier and males are the sufferer. By which genetic process a girl child can also suffer from G6PD deficiency?
Lionization.
Lionization. The answer is right. Give 10 marks to the team. तो अभी तक एक don't worry, अभी बहुत rounds हैं. So this is a unique lionization. Golden line to remember. In extreme case of lionization, the normal X chromosome could be inactivated. Okay, जैसे वहां पे हरे वाला है, हरे वाला get inactivated. लाल वाला is the one which carries G6PD. So there may be significantly reduced level of G6PD due to so-called lionization. So even a female child, despite having X-linked recessive disorder, the lady can suffer. So in fact, हमने 10 लोग टीम का तैयार किया था, 5 ही टीम आई है, तो never mind, we have one more. Continue करते हैं. Team 1. Binding of B12 to intrinsic factor occurs in which part of the GIT? Yeah.
Stomach.
Eh?
Stomach.
Stomach. No, answer is duodenum. R factor, B12 unite with R factor in the mouth and stomach. Intrinsic factor in duodenum or receptor in distal ileum, and the name of receptor is cubam receptor. So congenital deficiency of B12 because of the problem in the cubam receptor. Okay. Team 2. Biochemical relapse occur in which type of hepatitis? Well, the right answer is hepatitis A. A में होता है. Golden line to remember. Serum sickness hepatitis B में होती है, और hepatitis C में jaundice is mild or absent. Episodic rise of liver enzyme and cryoglobulinemia can occur in hepatitis C. Okay, team 3, mic दे देंगे. हाँ. In which congenital kidney disease hyperkalemia occurs due to chloride shunt?
The Barter's syndrome.
The answer is Gordon syndrome. Golden line to remember. Gordon के अंदर there is metabolic acidosis, hypertension, serum aldosterone level is reduced, and hyperkalemia is there. Team 4. Next team, team 4. Delayed bone marrow suppression is a side effect of which anti-cancer drug? Quickly. Well, the right answer is carmustine, lomustine. Now they are used for brain cancer. Or once you start the drug, the bone marrow depression occurs after 4 to 6 weeks. And very important point, only brain cancer which has a extracranial metastasis is medulloblastoma. एक ही कैंसर है जो ब्रेन का जो cranium से बाहर जाता है. Question 10. Which type of glomerulonephritis can occur in Hodgkin disease? Team 5. Quickly. The right answer is minimal change glomerulonephritis. Golden line, the causes of minimal change, mostly idiopathic in children. HIV, Hodgkin and rifampicin से हो सकता है.
But that is nephrotic, no?
क्या चीज? Glomerulonephritis can lead to nephrotic syndrome. Minimal change glomerulonephritis होती है, and that lead to a nephrotic syndrome. So this is round 1. Now we come to round 2, picture based. You get 15 seconds for each question. Team 1. With this type of tongue is seen in which condition? Team 1. Well, the right answer is a myasthenia gravis. ट्रिपल फरो टंग देखेंगे एक बार फिर. ट्रिपल 3 फरो आ रहे हैं इसके अंदर. एंड गोल्डन लाइन टू रिमेंबर, एज ऑफ इन्वॉल्वमेंट, फीमेल में यंग फीमेल होती है और मेल्स में एल्डरली मेल्स होते हैं. स्नार्लिंग फेज, ये जो स्नार्लिंग फेज है, क्योंकि बायलैटरल टोसिस होता है तो फ्रंटलिस मसल टेक ओवर कर लेती है. क्लासिकल स्नार्लिंग फेज. टीम 2, व्हाट इज दिस इक्विपमेंट नोन एज, या किसके लिए यूज करते हैं? Team 2. Plethysmography is the right answer. They get 10 marks. Well, RB, FRC. Helium dilution technique or body plethysmography. Team 3. What is seen in this sputum of a patient? Cashman spiral, no. This is Birbeck granules, so-called Birbeck bodies. They are tennis racket shape, seen in histocytosis X. और इसके CT के अंदर ये classical honeycomb appearance मिलती है. Team 4. What is this name of this sign?
Pemberton sign.
Pemberton sign, the right answer. Well, golden line to remember, this is seen in superior vena cava obstruction. Lung carcinoma is the most common cause of superior vena cava, especially small cell lung cancer. Non-pulsatile ray JVP. पोस्ट ग्रेजुएट के लिए इसको भूलना दंडनीय अपराध है. डोंट फॉरगेट दिस लाइन. नॉट ओनली वन कंडीशन वेयर वी गेट नॉन पल्सराइल रे जेपी इज सुपीरियर वेना का प्रोमिनेंट अपर चेस्ट पेन होती है, सामने नजर आ रही है. टीम 5, एमआरआई ऑफ सर्वाइकल स्पाइन, इट इज सीन इन व्हिच डिजीज?
Laryngomelia.
Good, correct, right answer. This is soap in bubble appearance. Soap in bubble appearance आ रही है ये वाली. Okay, and classically in syringomyelia you get dissociate anesthesia. There is bilateral loss of pain, touch and temperature. Position, vibration sense, they remain normal. Okay, cape-like distribution of pain. Team 1. A young man present with acute pain abdomen and has skin discoloration. What the cause of pain?
Acute pancreatitis.
Acute, right answer is acute pancreatitis. This is a flank pain, so-called Gray-Turner sign. Extra knowledge. You also get this periumbilical, this lining, and this is so-called Cullen sign. We also get Fox sign when the coloration occurs in the inguinal area. Next team. X-ray abdomen, easy question है. What is your diagnosis? Team 2. ये easy question है. मार्क भी कर दिया मैंने. या माइक देंगे फटाफट. हाँ बोल देंगे. Well, this is porcelain gallbladder. There is a calcification of gallbladder wall, and it is the main thing is it can lead to carcinoma gallbladder. Next team. X-ray of hands in which condition? Easy hai.
Rheumatoid arthritis.
Rheumatoid arthritis is the right answer. We have a rheumatologist sitting in the dais. So this is a typical, the golden line to remember. This is ulnar deviation of finger. उसके अलावा only part of vertebra involved in RA is cervical spine. Lumbar spine is not involved. That's why low backache is never a feature of RA. Sclera is involved. Uvea is classically not involved. uvea is involved in ankylosing spondylitis. And malignant rheumatoid arthritis, when extensive involvement of skin occur, then we use the term as malignant rheumatoid arthritis. Team 4, endoscopy of stomach seen in which condition? Team 4,
Watermelon stomach. Watermelon stomach, sir.
watermelon stomach is the right answer. Seen in which condition? Anyway, yeah, bole.
Diapholase lesion.
Say again.
Diapholase lesion.
No, no. Anyway, we give the answer. You give 10 marks. This is watermelon. Seen in scleroderma. Scleroderma, extra point. Scleroderma is the one condition where there can be sudden renal failure. Don't forget. Very, very important line. Scleroderma is the one condition where we have systemic hypertension and pulmonary hypertension.
Dr. 10 or 5?
10 marks.
10.
10 marks. Complex internal organ involved is lower end of esophagus. ये 3 बातें नहीं भूलनी है. Team 5. Extravagant seen with disease.
Gout, sir.
Gout is the right answer. Is the right answer. Well, golden line to remember. This is just X-ray है, Martel sign, G sign or red white sign. Golden line, acute gout is known as podagra, and grade 4 tenderness occur. Now, question open to all these 10 people who are. How do you do the grading of tenderness? How do you do grading? जो बताएगा उसको कप ऑफ कॉफी मिलेगी, नंबर भी मिलेंगे. हाँ. Anyway, partly right है. चलिए grading of tenderness ये आपको आना चाहिए. Grade 1 pain on touching. Patient cries on touching. Grade 3 he withdraws. Grade 4 he won't let you touch. He won't. And the causes of grade 4 tenderness are gout, septic arthritis, and arthritis occurring in rheumatic fever. Don't forget. So now we come to the third round. Oh, sorry, ये extra चीजें हैं. Yeah. Now we talk about round 3. Team 1. Earliest feature of diabetic nephropathy. Team 1.
Sir, raised GFR.
Raised GFR is the right answer. Microalbuminuria is the most common wrong answer. Right answer? Well, extra bateं. Capillary basement thickening is the classical feature of diabetic nephropathy. Diffuse glomerulosclerosis is the most common, and nodular sclerosis is the most characteristic. Team 2, most specific eye signs in grave disease. Quickly.
Wide staring appearance.
The answer is chemosis. ये जो चारों हैं, lid lag, lid detection, wide staring gaze, they are seen in all cases of thyrotoxicosis. But seen in grave disease are chemosis, proptosis, diplopia, proptosis, bulging of eye, chemosis, red eye. They are seen in grave disease. Team 3, which is not a feature of Kaun syndrome.
Sir, edema feet.
Edema feet, right answer. Correct. Kaun syndrome के अंदर extra बातें. Polyuria occur due to nephrogenic diabetes insipidus, which lead to hypokalemia. And hypokalemia से देर occur polyuria, और hypokalemia की वजह से muscle weakness होती है और distension abdomen. Best initial test to diagnose Kaun syndrome is plasma aldosterone concentration versus plasma renin activity is the best initial test. Team 4, alpha thalassemia is best diagnosed by. Team 4.
B. Nestrov.
No, Nestrov, no. Right answer is DNA analysis. So, alpha chain, there are 2 alpha chain, but 4 genes. अगर एक जीन नहीं है, चारों है तो नॉर्मल. एक जीन नहीं है, we call it silent thalassemia. 2 जीन नहीं है, we call it thalassemia trait. 3 जीन नहीं है, HBH, और चारों नहीं है, hydrophilialis. These patients don't survive जो hydrophilialis because there is no alpha chain. feature of sickle cell trait. Next thing.
Isosthenuria.
Eh?
Isosthenuria.
Isothinuria is the right answer. Sickle cell trait, golden line to remember. यहाँ पे there is fixed specific gravity होती है and hematuria. Normal blood picture, no anemia. लेकिन with hypoxia like scuba diving or going to Himalayas, they can lead to venous thrombosis, especially in splenic vein. Okay. Next team, which is not now team 1. Am I right? Team 1 ही है दोबारा ना? ठीक है sequence. Team 1. Tired of UTI में क्या चीज नहीं आती है? Easy question है वाला. Quickly. Well, the right answer is fever. No, you are late. You are late. Fever. हाँ जी. चल ठीक है. Fever ठीक है. There you are. Team 2. Which the following drug may be needed when we are treating a case of pernicious anemia with vitamin B12 folic acid? Team 2. Well, the answer is aspirin. Because when we treat with B12 folic acid for pernicious anemia, that lead to thrombocytosis, that can lead to clot formation. और उसके लिए we have to give aspirin to prevent the clot formation. And hypokalemia is a well-known complication when we are treating with B12. Team 3. In which condition type 3 respiratory failure occurs? Quickly.
Shock में sir, B में.
Oh, well, no. Answer is atelectasis. Atelectasis occurs in the post-op period. So that's why it's also known as perioperative respiratory failure. Type 4 occurs in any shock. और type 2 kyphoscoliosis और flail chest में type 2 होता है. Question 9. Cardiology in which of the following condition? Team 4.
BMR, sir.
MR, no. Right answer is TR. TR, tricuspid regurgitation. If you read 12th edition Harrison, उसमें लिखा है cardiologist in tricuspid stenosis. If you read 14, 15, 16 edition, उसमें लिखा है cardiologist in early TR. If you read 18, 19, 20, 21, cardiologist in TR. थोड़ा Harrison में भी फर्क रहता है, but as of now, the right answer is tricuspid regurgitation. The last question. Say again. इसका टाइम कम है, इसे परमानेंट वी वेव. TR. अच्छा. And the last question. इसके बाद ECG. हाँ. In which organ mixing of arterial and venous blood occurs?
Liver sir.
है?
Liver.
Liver. पक्का. Sure. Confident. लॉक किया जाए. आंसर लिवर है. ये जस्ट टू टेल यू बेसिक कंसेप्ट. देखेंगे ये रही वेन, पोर्टल ट्राइड में ये आर्टरी, ये जाके साइनोसाइड में मिलते हैं एंड अल्टीमेटली दे गो टू सेंट्रल वेन. ओनली ऑर्गन, यूनिक थिंग, नोवेयर एल्स इन द बॉडी वेयर मिक्सिंग ऑफ आर्टीरियल एंड वेनस ब्लड अकर इज लिवर. So this is my show. Sir, score क्या है so far? Now next round ECG का है and my colleague, कुछ और क्वेश्चन थे मेरे पास. Okay. My colleague Dr. Nityanand Tripathi.
At the end of 3 rounds,
हाँ.
T1 is 30,
30. Team 1 30. हाँ.
Team 2 is 10,
Team 10. Don't
Team
worry.
3 is 20,
20.
Team 4 is 20,
हाँ.
and T5 is when till now it's 40.
Okay, fine. ठीक है जी. So please continue.
There's an announcement. There will be prizes for the quiz competition.
Okay.
The 3 prizes
So team 5 के बिना.
will be rewarded after the inauguration. Thank you.
Thing in Epicon हो रहा है अहमदाबाद में 26, 29, 29 को मेरा क्विज है, वो 5 घंटे का है. I will make you revise the whole medicine. हम तो यहाँ 30 मिनट, यहाँ तो खाली 20 मिनट मिले हैं. Okay, so all are cordially invited and must stay on 29th morning. कौन सा? वो आपका वो पूरा ठीक नहीं था, आपका पार्टली ठीक था वाला। सर प्लीज कैरी ऑन।
So, this is ECG in round 4. So, I think the better thing will be any team can answer.
No, no, we go by sequence.
So, then it will be difficult. I think that will be
चलो,
good.
what he want, any team can answer. Done
The
that.
team which recognizes first
ठीक है,
raise their hand.
good.
But sir,
Tell me.
this will be pass कर दियो, but it should be system 1 2 3 4 और अगर नहीं तो पास कर दो, उसमें क्या दिक्कत है? दूसरा
That's
है ना?
that-
अगर सब मान लीजिए 5 टीपी बने, 5 भी अगर आंसर difficult
टीम देगी नहीं तो इस यहाँ पे पास अलाउ कर देंगे। चलो,
Can you recognize it? If not, then pass.
then pass.
30 seconds.
Sir, pulmonary embolism.
No.
डायग्नोसिस क्या है?
What's the diagnosis? This young man in shock gave you the chest pain. Is it
नहीं,
wrong?
wrong. Team B, team
Team
B, team C, team D, and team E.
Yes, please.
Ventricular tachycardia.
Pardon?
Ventricular tachycardia.
No. It's acute interval MI with RBBB.
RBB or by
Young man with chest pain and shock, you can see there is a ST elevation. Here you can confuse with the broad QRS, but when you see the QRS here, it's hardly 120. Here QRS is not 120, it's more than that. So that means the ST is merged with in the QRS, and in fact QRS is this much only. And this is ST segment elevation, this is ST segment elevation, this is ST segment elevation, and this is RBBB. So RBBB with ST segment elevation in all anterior leads, this is extensive anterior wall MI. And since right bundle branch is involved, that means deep septum is involved. So it's a patient is sick, the patient is in cardiologic shock, and this is anterior wall MI. What is catching point? You can see the QRS here, the narrowest part of the QRS here, but here QRS is very wide. So QRS cannot be wide in one of the leads and can be narrow in another of the leads. If QRS is wider, then it will be wider in all of the leads. And this is the ST segment, because you are not able to see ST segment anywhere in these leads. While ST segment is here, you can see it clearly. So it's a ST segment elevation MI with RBBB. Obviously, this is sinus tachycardia. So when you are analyzing the ECG, I suppose that you know how to analyze. Go by rate, rhythm, axis, QRS, PR interval. Then there is any other findings, like in the previous one there was RBBB, and typically it is known as QRBBB. You can see a Q wave just before the RBBB, and when QRBBB is there, that's a typical sign of the CV, there's an extensive infarct. And the diagnosis is acute in ST segment elevation anterior wall MI with QRBBB indicating extensive infarct. So team 2, what's the diagnosis? This person presented with the palpitations in ER.
किसके लिए सर?
Palpitation in ER.
सर किसके लिए कुछ नहीं?
Emergency room, young man presented with palpitation.
Excuse me, sir.
No, it's not in. Team 3. Go by rate, rhythm, axis, any extra findings. Speak loudly.
So this is left axis deviation with no P wave visible. And
Tell me the diagnosis. You are MD.
See, what the question? Question is the palpitation and was also given.
So atrial fibrillation is the most common.
No. See, atrial fibrillation typically.
Next team.
The junctional tachycardia.
No.
P waves, regular rhythm.
No.
Somewhere near. So it's.
Team 5, team 5.
Sir, can it be hypothermia?
Hypokalemia.
Hypothermia.
Time up.
Hypokalemia will have
Which
you.
one?
Time up.
Osborne wave, sir.
AVN RT. Why AVN? Too small steps, 150. That is 150. There is a RBBB, small notch on the R. There is something here.
So isn't
These are
that
the-
Osborne wave in V3?
It's a retrograde P waves. So it's AVN RT. AVN RT, why? There is the retrograde P wave is within 70 milliseconds. 70 milliseconds means 0.07 seconds of the QRS, last part of the QRS. If it is within 70 milliseconds of the last part of the QRS, it is AVN RT. When it is more than 70 milliseconds, it becomes AVRT. So it is AVN RT, patient presented with the palpitation in the ER, and the typically the aberration is RBBB. Why RBBB? Because right bundle is thicker and it tends to fatigue first compared to the left one. That's why whenever there is a tachycardia, usually you see the RBBB, right bundle branch match. And because P wave is marching with the T wave, so you might see the ST segment depression in chest leads. So ST segment depression in chest lead again goes in favor of the AVN RT. So this man is AVN RT, and what is the treatment in ER? You give the adenosine or deltiazine. What is diagnosis? Team 3.
Team C.
PSVT.
Okay, PC शुरू हुआ था.
Speak loudly.
PSVT.
Yeah, good. PSVT. Can you speak number? It's good, but can you specify further? We just discussed. If you can identify.
AVNRT.
No, it's a AVRT. It's a PSVT, AVRT, RBBB remains the frequent findings. But when you see this is the P wave, this one is the P wave, this one is the P wave, because this is changing. Here this is the P wave, here this is the P wave. These P waves are like they are more than they are almost 80 milliseconds after the QRS. So it becomes the AVRT, though it might be present in atypical AVNRT as well. So it's a very difficult to differentiate absolutely clearly that patient is whether AVRT or AVNRT. But once you can see the P wave clearly, then it's a AVRT. So this patient is AVRT. It's electrophysiologically proven AVRT, and previous one also electrophysiologically proven AVNRT. The
Team C.
team 4.
No, first.
What is the diagnosis?
Dr. Tripathi, what would be marks for last questions?
Sir, team
He also gave PSBT.
PSBT.
So,
Yes,
but
PSBT.
yeah, so 10.
10, yes.
So diagnosis. C23 AVF, patient is young,
Team 5.
around 10 years of age, female. C23 AVF and B1.
Team 5. No. Team 1. 2.
I further give a hint. Yeah, can anyone recognize?
Sir, inferior wall MI.
No. So it's a something congenital heart disease. 10 years old female will not have any MI. Pardon? Yeah, AST is somewhere near.
So why septum secundum? You are right. Okay. This is protest sign.
Sir, it is a
Very specific for ostium secundum. AST. RBBB. It's a RB overload in AST. So you usually get the RBBB. It's a protest sign. This is protest sign.
totally a science, sir.
Yeah, the top of the RBB is notched. And it is 98% specific for ostium secundum AST. It's a very good.
Did you answer the question?
Yes, sir.
We are going to give
This
marks.
this is what you saw already. So what is your diagnosis? Team 5. Patient 37 years male, presented in ER with chest pain. Chest pain after
Sir, pericarditis, sir.
T1, 2,
Sir,
3, 4,
Chest pain 2 hours duration, 37 years.
sir, hyperacute T waves
It's a
in
if it's an anterior MI, you can see there is AST depression, hyperacute T waves, and this sign is typically known as D Winters sign. And D Winters sign is ECG abnormality described by D Winter in 1998 recently, characterized by 1 to 3 millimeter AST depression and upright symmetrical T wave. This is the most important. Changes are dynamic, and if you wait for another 1 hour, there will be frank ST elevation here. It's a suspicious proximal LED, very typical, and represent approximately 2% of LED occlusion, recognized as a STEMI equivalent. And you have to take this patient either thrombolize or take for a private PDCA. It's a D Winter sign in acute interval, very specific. What is this? Team 1 again. There are 5 teams. Team.
Dr. Jha, have we got time to
Take-
continue or
take
should
one.
we stop here?
Team 1.
sir, yes. Left bundle branch block with LV strain. Sir, inferior lemma.
No.
Team
See
second,
more closely.
team 2,
नहीं तो यही बंद करते हैं इसको यहाँ stop
See.
Sir, WPW syndrome, sir.
It's a WPW syndrome. You can see delta waves.
पूरा राउंड होगा 4 क्वेश्चन और होगा
Short PR, delta waves. It's a delta wave. And when there is a tachycardia, it will mimic as a inferior anterior wall MI or LBBB or even mimic as a VT. This is typically confused with the VT when you see it. Typically confused with the VT. And I think
Next.
this is the left posterior septal pathway. And what is diagnosis here? This ECG has many findings. This is 7, so 5, 6, 7, team 2. Go by rate rhythm.
team 3,
If you don't go systematically, you will get confused for sure. This is very simple ECG. Go by rate rhythm.
team 4,
Team 4.
team 5. 10 skins for any team.
Pardon?
First degree heart block.
माइक ले
First
लेंगे
is the heart block. No.
चल नेक्स्ट
So
Sir.
it has multiple
Sir, excuse me.
multiple findings.
Excuse me, sir.
फटाफट आगे चलो
Sir, prolonged QT syndrome, Romanov.
So time is less. So we will go. I will explain you. This has multiple findings. You can see deep symmetrical T inversions in anterior leads. The T wave character is changing, and there is a P wave. So this P wave is same. It's the 2:1 block with hypertrophic cardiomyopathy, typical of the hypertrophic cardiomyopathy.
Next.
Typical of the hypertrophic cardiomyopathy with 2:1 block. I said you go by whenever you see a ECG, and if you go by impression of the ECG, you are going to miss the findings and you are going to make a wrong diagnosis. Go by rate rhythm axis and then QRS, PQRS relationship and extra findings. This is
Team three.
Team 3. Huh? Team 3. Go by rate rhythm QRS. This is 58 years male presented with the syncopal attacks.
Third degree AV block.
Near to it, it's a high degree AV block, 3:1. 1, 2, 3. So there can be like the same P wave can be exactly 1/3 of the QRS, even then it can be complete heart block as well.
Second degree AV block, Mobius type 2, sir.
Mobius is yeah, it can it's go fine. It's acceptable.
Time to come next.
This is the last.
The points, sir.
Someone asked the question.
Last question.
Dr. Tripathi,
Last.
someone answered the
Team
question.
4. Team quickly. Team 4.
Anyone can answer.
Ah, this is the-
So I think there is less, we have very less time, so I will.
Team 4.
It has multiple findings. Anyone? So there are multiple findings. You can see this is one, this is one, this is one, this is one, this is one. So there is bidirectional VPCs. This is a fusion beat. This is a fusion beat. This is the VPCs. This is what I intended to show you in this ECG.
Tamponade.
Multiple fusion beats and bidirectional ECG.
Last slide.
This is most important slide. So what is diagnosis?
Anybody raise your hand?
Team 5. Team 5.
Any team? We got less time. Any team?
Chest pain for 2 hours duration in percentage in cardiac.
Inferior wall MI, sir.
It's multivessel disease. It's known as AVR sign. You can see there is a segment elevation in AVR. There is a multiple ST depressions in almost all leads. It's a typical for multivessel disease or left main. This is known as AVR sign.
चलो ठीक है बस that's okay finish. हो गया सर हो गया that's all.
I think the participants should not get discouraged. All these ECG are on level of DM cardiology. We are not even ready in MD and MBBS.
चलो जी
Don't get
this
discouraged.
all is end.
हाँ, final score.
So we tell the score. So thank you so much all the participants for a very good participation. Thank you, Dr. Tripathi and Dr. Mukesh Bhatia for the wonderful presentation. At the end of the score, end of the quiz, the winner is Team 3, score 50. Second is Team 5, score 40. Third is Team 1, score 30. And fourth is Team 4, 20. And last is Team.
Anyway, all of you have done very well. Thank you very much for participation. Congratulations to all of you. Time से खत्म कर।
Now request the chairperson to honor our moderators, Dr. Tripathi and Dr. Mukesh Bhatia.
सर मैं टाइम से खत्म कर दिया हमने टाइम से खत्म कर दिया
Please come this side. अब दिख रहा है गोयल उधर दिख रहा है ठीक है ये दिख रहा है स्क्रीन ये स्क्रीन मेन स्क्रीन
ये माइक
ठीक है ना So by the time this photography session is going on, we'll start the next session. The next session is challenge insulin therapy. This is a workshop, very interesting workshop. And the moderator is Dr. Deepak Khandelwal. He needs no introduction. He's a very renowned endocrinologist practicing Paschim Bihar, has got a very renowned clinic and is very young and very dynamic endocrinologist. And the panelists are Dr. Saket Kant in person. Dr. Saket Kant, senior endocrinologist working in Max Hospital, Shalimar Bagh, as well as Saxon Balaji Hospital. And we have got two eminent panelists, Dr. Shashank Joshi. No need of introduction. He is a great cardiologist practicing in Mumbai. He has been past president of API, RSDI, and a very renowned international endocrinologist. And Dr. B.M. Makkar, our own member. He is the president of RSDI at the present and practicing in Paschim Bihar. So they will come online, Dr. Joshi and Dr. Makkar, and physical is Dr. Saket Kant. And I request Dr. Nityanand to please come and join as a panelist. Nityanand, please. Now I request Dr. Deepak Khandelwal to start this. Achha. There is an announcement. We are going to poster presentation. So who are participating in poster presentation, please go to the stall and give their posters. And there will be prizes. There will be 3 prizes for the poster presentation also. That will be given after inauguration. अच्छा ये लाइन पे हैं डॉक्टर जोशी एंड डॉक्टर मक्कर.
Very good morning to everyone. Sincere thanks to NDPF, Dr. Chhabra, Dr. Jha, and everyone for this wonderful opportunity. And I think it's a very interesting hybrid panel discussion or symposium on challenges in insulin therapy. So we have one of the panelists, Dr. Saket Kant, sitting here, and I think 3 persons are joining online. We have Dr. Shashank Joshi joining all the way from Mumbai, very renowned endocrinologist. We have Dr. Sanjay Kalra sir from Karnal, again, very renowned figure in the field of endocrinology. And we also have very renowned diabetologist, Dr. B.M. Makkar sir, also joining online. So, can we have our panelists also? Can we see our panelists who are joining online? So the topic is challenges in insulin therapy. So, Dr. Saket, would you like to let us know the 2 most common challenge that you encounter in your day-to-day practice regarding insulin therapy?
Thank you very much for that question. So what basically in routine clinical practice, the most common challenge is the patient is going to come to you and ask you whether insulin therapy once started would be for lifetime or not, because they are very much concerned about this. They may say that they have seen their relatives on insulin therapy, who had nephropathy later, who had cardiac disease later, and they link all this to insulin therapy. Whereas you have to explain to the patient that it is the other way around. When you have some diseases like nephropathy, kidney disease, or when you have some pneumonia or any infection, UTI, the insulin therapy may not be, it may not be permanent. It may be temporary. It may be given for some time, and then the patient can be on OADs again. The second most common challenge would be the phobia of needles and insulin. That can always be taken care of if you demonstrate insulin therapy at the clinic itself. And then, of course, the risk of hypoglycemia and weight gain, that is both a concern for the patient as also the physician. So counseling, I guess, is very important whenever you start insulin therapy. Tell the patient it may not be lifelong. For many patients, for patients for whom it is lifelong, let them know at the offset itself. Demonstrate the first injection at the clinic itself. You can always demonstrate yourself so that you can decrease the risk, decrease insulin and needle phobia, and counsel regarding hypoglycemia as also weight gain. How can they minimize weight gain?
Okay. Thank you. Just correction. We have got chairpersons for this session of the workshop. Dr. J.K. Sharma, Dr. Sharma, sir, please come, sir. I'm sorry for the. He is a well-known physician and he is presently president of RSDI Delhi chapter. Dr. Anish Gupta, renowned endocrinologist practicing in East Delhi. Dr. Rajeev Diwan, he is a senior consultant, Saroj Hospital, Rohini. Thank you. Please continue.
Thank you. So I need to confirm if any of the panelists is. Okay, fine. So I think Dr. Saket Kant highlighted two important challenges. One, patients believe it is going to be the lifelong treatment. Second, needle phobia. So if Dr. Kalra is there online, sir, because you are practicing in, in Karnal, Haryana, and you have been practicing for so long time. So has the practice has changed over a period of time in the last 3 decades, meaning whether the insulin initiations has become easy or more acceptable, if you are able to answer. Maybe Dr. Gupta sir, you want to take this question. Dr. J.K. Sharma or Dr. Anish, you want to take this question. Whether in the last 3 decades, the insulin initiations has it become easy or more acceptable?
The journey of the patient has become better. Also, what has helped is that earlier insulin used to do only a painful therapy. Every time when you are guiding the patient, if you have to start insulin, they had the memory of their granny or their grandfather taking injections of insulin. The delivery mechanism of insulin has improved. We are using pens. Those pens and the needles that we are using today have almost made insulin 55 less. And once we demonstrate to the patient that, this is the therapy that we're going to use, they're going to use the pen, the things have become slightly easier. The delivery devices, the technology that has come, usage of insulin, delivery of insulin, the system of insulin, that has improved a lot. And probably that is one of the reasons that has helped in making the patient more compliant with insulin also. And also, in the initial insulin conversations, now the patients are knowing that insulin is not a therapy which is going to make their life lesser. Because earlier there used to be a myth that it's the last resort therapy. Once they are going to start it, there is not going to be any medicine. Now the patient comes to us, sometimes the patient is so much said that I want to start insulin because it is good for me. And that's the way the journey has become.
So I think important points highlighted by Dr. Anish Gupta, awareness has become better. The insulins, they have become better over a period of time. And the delivery mechanism for insulin, they have also become better over a period of time. So maybe Dr. J.K. Sharma, sir, I can take this question from you. Once you decide that, this is a patient of type 2 diabetes, you want to start insulins. So how you initiate insulin conversation with your patient?
Thank you. When we decide that this patient needs insulin initiation at the earliest, if the patient is coming to us for the first time, and if the HbA1c is more than 9 or 9, at the initial stage, we should convince the patient for insulin initiation. And we can explain the patient that maybe for 2 to 3 weeks to overcome the acute glucotoxicity, we should start with insulin. And once we spend little time with the patient, convince the patient, it becomes easy nowadays, as Dr. Gupta said, with the good quality pen, state-of-the-art devices. And I don't think that many patients refuse for this. The basic thing is that counsel the patient properly, tell how we are going to initiate, what we are expecting out of this, and then it becomes easy.
So I think important message from Dr. Sharma, good counseling and, the counseling of the patients and the family member is very, very important. Dr. Saket, we have often patients in practice, they don't want to start insulins. And if I was discussing yesterday with Dr. Kalra, कि OPD में 3 तरीके के patients आते हैं. मैं इंसुलिन नहीं लूंगा, मैं इंसुलिन नहीं लेना चाहता, और मैं इंसुलिन नहीं ले सकता. So we can have 3 kind of patients. I will not take insulin, I will not like to start insulins, and I cannot take insulins. So the first category, please, would you like to address? I will not take insulin.
I guess it is very important to sit back with your patient and counsel your patients. Tell them that insulin would be temporary for most of the patients. They would agree on that. Demonstrate, I guess that is what I was talking about. Demonstrate the first injection in the clinic itself. That would, decrease the phobia of needles and insulin. Let the family be there when the patient is being counseled. And you always have to explain the process of insulin, that if you take insulin for this time, probably your medications that are basically not working because of glucotoxicity and lipotoxicity would start working, and you've got a lot of therapies now. You've got a lot of oral drugs that are very useful. But at times when you have very high glucose levels, you can always tell them that if they are losing weight, for example, that they'll start gaining weight. Insulin is the safest therapy at that time. So I guess sitting back and counseling a patient, even if the patient is adamantly refusing insulin, would take care of that in just about 99% of your patient. So you'll have to give 15-20 minutes of your time to that patient, counsel regarding the benefits, counsel regarding the side effects. Tell them that it is not always permanent that the patient is going to take insulin. Counsel regarding hypoglycemia, counsel regarding the weight gain, and probably you're good to go even in patients who are adamantly refusing insulin.
So I think what Dr. Saket Kant is again emphasizing, we need to sit with the patient. We need to discuss with the patients and their family members. We need to address their concerns, and counseling and more counseling. I think that is the answer. Dr. Devan, one more category I was talking about, मैं insulin नहीं ले सकता. And there can be some, reasons for that. So how would you like to take those kind of patients?
There are two main reasons, but I'm saying there are two main reasons. They say that if you start and say it will be right one. Number one is without care in the mind. Even if you start with a short time, one doesn't hospitalization or if you come in very high, but they not. Number two doubt in their mind is that if they start an insulin with the end of the day. There were the people around them, they will say that, oh, you are actually now in. These are two basic questions in the mind of the government manager. If you address these two questions, most of the patients are finished. I have seen it. Because they have this in the mind, oh, no, my life is finished, I am listening. What do the people say? If you ask them, they will say these two. So I always address these two questions, and many of them they agree. Because unless we solve these two issues, they will never agree.
So thank you, sir. So I think what again Dr. Devan is trying to emphasize, they have certain myths in their mind. They have listened to certain things, and I think again addressing their concerns and proper counseling is the answer. Among the audience, anyone has any doubt regarding insulin initiation or any questions you want to have with the panelist? Anyone? So Dr. J.K. Sharma, sir, you have I want to because you must have so many of patients who were very, very difficult to start on insulins, and eventually you should have you must have started them on insulins. So any good examples from your practice you would like to tell the audience where the patient was very difficult but eventually you were able to start on insulin?
The very much phobia, the needle phobia is very important, and if you give the first dose of insulin at your clinic, either by our educator or by our nurse, or even you can give yourself to your patient the first injection, and that is really giving satisfaction to the patient also, to ourselves also. And in that case, patient starts with the insulin. Second thing is that availability. They have an apprehension that suppose with insulin my sugar levels go down, and any episode of hypoglycemia once in lifetime of the patient is really scary, and it becomes difficult to continue insulin in such kind of patients. So be available to the patient. Maybe initially he may ring you 3 times, 4 times. And if you ask your patient that do the SMBG and report to me, at every time, it hardly takes half a minute to satisfy the patient, to guide the patient that, look, this is your blood sugar level and this is how you should react or behave. And that becomes very easy. And this is the practical tip which I want to give. Please spare some time for your patient in the initial stage when we start insulin. That is what I want to say.
Thank you, sir. So I think very important messages from Dr. Sharma. One, if the first dose can be given in your office, whether you want to inject that insulin, whether you're nurse or educator or someone, the first dose, I think almost 95% of fear of the patient goes when the first dose is being given into the clinics. And then second, as he very well highlighted, they have fear of hypoglycemia. So in the same line, Dr. Anish Gupta, sir, one, when you are using insulins in your practice, one, how can you minimize the risk of hypoglycemia? Second, the hypoglycemia is eventually a reality when the insulin therapy is there. So how can you minimize the impact of hypoglycemia?
So what I think is that education about hypoglycemia at the very beginning of any kind of therapy, whether it was hypoglycemic treatment or insulin, is the pivot which we can establish in hospital. When we are treating a patient of diabetes, we are all dealing with a regular work because all medicines are diabetes or diabetes are made to bring down the hospital. And sometimes the patient's response to the medicine is going to be very great because there is no thing like exception in medical science. You can always encounter exception at any medical point. And whenever the patient is encountering a hypoglycemia and educating effort by you from the very beginning that the patient is going to have such kind of episode is going to save a lot of effort. So if you can already direct them that this is the situation that might happen, then later on might not have a first benefit from our. On the other aspect, I also want to say that reason of hypoglycemia is the reason behind the inertia that all of us have towards it. We start out with the robust dose of insulin despite knowing that this patient is not going to have benefit to 10 units or 20 units. We start with a very low dose. And sometimes that is what makes the patient lose the patient. We start with a very low dose of insulin, the patient comes back to us and says, Dr. So my take on this is that we should always start with a robust dose of insulin to begin with, because if the patient is going to have very good blood sugar control at the very beginning, then its patient is not going to do it. We start insulin, we are starting with the low dose because we are also having inertia and that hypoglycemia is going to happen. And then the patient who was coming to us around 300 milligrams, he is coming down to 50, 280. He says, Dr. Now, insulin to prescribe for you, I said, you are. And then he says, this for and then we don't have an answer for that. So whenever we start insulin, educate the patient about the risks of hypoglycemia, always start at a balanced, robust dose so that we can have good reading at the reading speed at the beginning. The patient might have a very good blood sugar control. His confidence in the insulin therapy will grow, and that will be the reason that we will continue on the insulin. We start with very low doses, and later on the patient starts getting it. So don't follow that.
Thank you, Dr. Anish Gupta. So, Dr. Sakit, I think there is a important message as Dr. Anish Gupta was talking about, and I think it is important in practice also. Patients, you initiate insulins maybe 1 year back, they keep on taking the same dose of insulins. Follow-up is you can see the poor in practice, and after 1 year ki sir ab hum 1 saal se insulin le bhi rahe hain, abhi bhi mera HbA1c 9 hai ya 9.5 hai, to isse to mujhe kya fayda hua? So what can be the reasons why in spite of taking insulins now still the glycemic control is poor? What went wrong, whether we were wrong or whether the patient was wrong, and what could have been done?
I guess equally important as initiation is up titration of insulin. You have to up titrate insulin to achieve your targets with minimal risk of hypoglycemia. So your up titrations can be physician based. That would be very difficult for you, but you can easily teach your patients also to up titrate, because now if you see, most of our patients would be on a basal insulin because of the plethora of drugs that we have to control the postprandials. So not many of our patients would be on pre-mixed insulins or basal plus. We don't have many. We used to have many patients on these therapies 5 years back, but with the advent of newer therapies for postprandials, especially GLP-1 receptor agonists, DPP-4 inhibitors, the good use of AGIs now, probably most of our patients, I guess you'll agree, that would be on basal insulin. So it's very easy to up titrate basal insulin. That can be taught to the patient based on the half-life of the insulin that you're using. So I guess the better regimens that are there are regimens of up titration 1 unit per day, but I don't go in for that. 2 units every 3 or 4 days make more sense based on the half-life of the insulin that we are giving to our patients. So tell the patient that it is not only initiation that is important. Initiation is just to decrease the risk of hypoglycemia, to make you acquainted with the insulin therapy. Up titration to achieve your goals is also very, very important. And up titration, you can always teach the patient, and you can make yourself available for if there is any confusion in up titrations. You can just give support to the patient for the initial 4 to 5 weeks regarding that, and then the patient will up titrate. So many of my patients who are basically taught up titrations, they do well. They come back to you. And the second is they have to have good follow-up. If they come back after 1 year on the same dose, I guess that does not make sense.
So I think the important message given by Dr. Hanish and Dr. Saket Kant, that optimal titration does not happen in practice. And probably, it may not be always feasible at the level of physician. We need to taught our patients and their family members the optimal importance of titration and how to titrate insulin doses. So any questions from the audience? You have expert panel sitting. Yes, sir.
What about the poor people from UP that are also being SPM the rate of 11 and self-monitoring is not possible with them. They are not educated enough. So how to deal with such setup?
Very, very, very important question. And Dr. Devan, would you like to take this question?
This is a very valid question and a very good question for this woman. We have to address the fact that the people who are living at the fringes of the society, they are lean and thin also. And lean and thin patients, they require insulin more than the patients who are coming to us with a high BMI. And these patients, when they are coming to us with a HbA1c of 10%, as we pointed out, 10% or more. So SAVC is not something that is very much required. Of course, it is very valid, and sometimes they don't have the education to deal with it. But they can be asked to come frequently to the clinic for the titration, number one. The second thing is that they should be explained that they are going to lose a lot of body mass, they are going to lose a lot of muscle mass, their own survivability is going to become problematic, and the multi-organ dysfunction, the multi-organ problems that they are going to face, that is going to be enormous. So these are the patients who require insulin more, and also not just for the organ preservation and for their body preservation, but also for the fact that sometimes these patients they cannot afford the new medicines like SGLT2 inhibitors, like oral semaglutide which is available, or the DPP-4 inhibitors, or the cascade of medicines that we are having. So insulin therapy becomes less expensive for them. If you go for the conventional insulin therapy is much less expensive for them than the whole cascade of medicine that you are going to prescribe as oral hypoglycemic. So if we bring these factors to them, we have a proper insulin workshop, not workshop, but insulin backup in our clinic. There is a nurse or there is a diabetes educator at the clinic who is always in coordination with them. Then I believe that we may sort out their problem, and the doctors will have a responsibility for those people as well. Not just for the higher class of society, but those people as well. And if we are able to treat them, the results are absolutely fine. They are much more gratifying because they are probably the only breadwinners of their family. And if we are saving them, we are saving our family, not just the patient, but the entire family. That's my take on it.
I think very, very important point, very important question, and very well answered by Dr. Hanish. And I would actually agree with him. And in fact, in most of the government hospitals in Delhi, all conventional insulins, regular insulins, NPH insulins, and even pre-mixed insulins, they are available free of cost in form of vial and syringes. Vial and syringes are equally effective. There can be some issues using them, but if you train your patients, their family members, they can very well take that. All conventional insulins are equally effective. Your modern insulins may have lesser risk of hypoglycemia. That can be the only advantage. But all conventional insulins are equally effective. What is really important, whenever you are putting any patients on insulins, hypoglycemia should be explained to the patients and the family members. The most common problems arises because they are not able to recognize hypoglycemia. 5 days back only, one of very renowned dermatologist of Paschim Bihar, wife is also a doctor. I was treating them for last 1 year on insulins. When they had hypoglycemia, they actually went to emergency, got first thing the ECG done, and then somebody said, get the RBS done. It was 40, and they were not able to even recognize that why this sweating and everything is happening. So let me tell you, because the main challenge is that people are not able to recognize hypoglycemia. You must tell them any acute symptoms in a patient in diabetes. The first thing that should come into their mind is hypoglycemia and correction of hypoglycemia. And as Dr. Anish Gupta rightly said, sometimes they may not have available glucometers or something like that, but if they feel symptoms suggestive of that, they must take measures to correct hypoglycemia. So I think any questions from audience? Yes, sir. Yes, sir. Agree.
That is important thing. And it's not very costly. It's a cost effective if they do at home. But only thing I would to impress upon them that they should do it.
Thank you, sir. We have Professor Richa Devan sitting here. Madam, any comments from your side?
No, I think he's made that very valid point, and that's important. And the panelists have given all the key features which should be done. I really thought that it's important to recognize these acute symptoms, especially hypoglycemia at home only. And as doctor said, that we can test it at home. And a lot of our patients, they're able to make a diagnosis themselves. Like if they're educated, they are able to do it, and they can also they take treatment and they also reach the hospital.
Thank you, madam. If we have any of the panelists who have joined online now, we can have comments from them. Otherwise, I would request Dr. J.K. Sharma and Dr. Saket Khan to give the concluding remarks. If we have Dr. Kalra, or you can see if they are there online.
One comment I would like to make, just one comment.
Yes, sir.
As Dr. Khandelwal pointed out, for a country like ours, I think pre-mixed insulins still have a very significant role. Maybe worldwide, they are ignoring premix now, no more. But for a country like ours, still premix has a role to play. And that's very important. 4 times in